So it is noon already. I'll just let people know. We are probably going to start just a couple of minutes late. Our presenter was stuck in traffic, so we'll just hopefully he'll be able to join us in a few minutes.
Sorry I'm late, guys. I wanted to drive in to do this because my internet at home is not stable, and I got a train.
Oh.
That was wonderful. But so do you want me to go to, do you want to just do it from your slides, or do you want me to go put up?
My slides are up, Charles, so if it's okay, you can just let me know next slide. I'll just do a quick introduction, then pass it on to you, and just let me know when to move to the next slide if that works.
Okay, great.
Okay, great. Thank you. So I think we'll just give people just another minute or two to join in, if that's okay. So
Ida, can I actually, one thing I didn't ask you, and for me to understand as we're embarking on this and can sort of alter my approach to the discussion is, where are the trainees from? Who are they? Are they PhDs? Are they MDs? Are they GI fellows? Or who are they?
It's a mixture, Charles. So we even have research coordinators, investigators on the line. So it is a broad audience. We did obviously extend the invitation to our network, inviting people in their institutions to join. So I imagine it's a bit of a broad spectrum of an audience.
Okay.
Yeah. And we will do about 45 minutes for your talk, Charles, and then we'll have about 15 minutes for questions for people to ask at the end. And we'll do that by asking people to enter their questions in the chat box, and then I'll field those and ask them out loud so that you can answer. So you don't have to go through the chat room to find them.
Sounds good.
Okay. So I think we'll probably get started right around now. I imagine we'll have a few more people joining us. But first of all, welcome everybody to the Imagine monthly webinar series. This is the second webinar that we've hosted. So we are really excited about this opportunity for trainees, for members of our network to learn about how best to improve research in their respective areas. We're really excited to have Dr. Charles Bernstein lead today's webinar, and the topic is obviously on designing successful IBD clinical trials. Before I pass it on to Dr. Bernstein, just a little bit about our Imagine network. So Imagine is a research network, and we're investigating the interactions between inflammation, microbiome, diet, and mental health in patients with IBD and with IBS. Our mission is to transform the management of these diseases and the associated mental health issues associated with them. A few housekeeping items. As I mentioned, we do want to reserve a little bit of time at the end of the session for people to ask questions. So we invite you to write your question in the chat room area, and I'll field those questions and then give an opportunity for Dr. Bernstein to answer them. So if you have a question, just type them in at any point in the webinar into that chat room area. And just another quick reminder as well, there will be an evaluation email sent to you after the session. So we invite your feedback. Please complete that. It is helpful for us to improve our webinars going forward. It's a great way also for us to be tracking participants that attended. Just so you know, this webinar is being recorded, so we will have it archived and available on our website as well. And you're able to view our past webinars on the website as well at imaginespore.com. Okay. So moving on, our speaker today, as I mentioned, is Dr. Charles Bernstein from University of Manitoba. Dr. Bernstein is one of the co-investigators in the Imagine Network and is our lead of the IBD working group. He graduated from University of Manitoba from medicine and the UCLA Division of Gastroenterology Fellowship Training Program. He's a distinguished professor of medicine. The list goes on here in terms of his accomplishments. Bingham Chair in Gastroenterology Research. He's the director of the IBD Clinic at the University of Manitoba, a fellow with the Canadian Academy of Health Sciences and the Royal Society of Canada, their science division. He's developed one of the largest validated population-based databases of IBD in the world, and his main research areas, interest areas are related to IBD, optimizing management approaches, exploring predictors of clinical outcomes, and the disease etiology. And of course, he's published over 500 peer-reviewed papers. So we're very excited and thankful that Dr. Bernstein has agreed to lead today's session. So I'm going to pass it over to him. And Charles, just let me know when you want the next slide moved.
Thanks, Ida, and Imagine team, and welcome to all the trainees. And some of you on the webinar may not be trainees per se, but involved in clinical research in IBD, and these are my disclosures from an industry perspective. Obviously, I have research funding from elsewhere that are peer-reviewed, but in any event, these are my industry disclosures. Next slide. You can't start a Canadian lecture and venue without identifying one's CanMed roles, and 10 years later, I really don't understand CanMeds. So next slide. So we're not going to talk about clinical trials from the perspective of pharmaceutical industry randomized controlled clinical trials. We're going to talk about clinical research studies. Imagine falls into that category on a very large scale. We're going to focus on inflammatory bowel disease, although much of what I'm discussing is really interchangeable with irritable bowel syndrome or any other chronic immune-mediated inflammatory disease. One of my research interests over the last 15 years has been studying the intersection of inflammatory bowel disease with other chronic immune diseases. And right now we're in the midst of a large cohort study co-led by Ruth Ann Mary, who's a world-class MS epidemiologist, and we're studying in a big way the psychiatric comorbidities of IBD, rheumatoid arthritis, and multiple sclerosis, but we're studying other aspects of how these diseases intersect. And so there's a few approaches that we've taken over the years, and I'm going to run through some examples of these studies that are both cohort design and also case control studies. We have one study that in fact was a cohort study in which we embedded a case control study. We're going to look a little bit at IBD assessment tools. I've not created slides per se on working with industry or engaging patients in study design, but I do think those are very valuable areas to discuss. And I do believe that there'll be time left at the end of my slide presentation so that we can raise some of these issues about working with industry and engaging with patients. And if for whatever reason I forget, Ida will remind me, because she's, I'm sure, making a note right now, remind Charles to talk about working with industry and engaging patients in study design, or, you know, hopefully there'll be questions alluding to that. Next slide. So in any research question, you have to develop your question. So you have an idea, and your idea is formulating, you know, the area that's of interest that you think is an interesting topic that you want to pursue. Some people may have this sort of fearful notion, I'm not going to tell anybody about this because this is such a great idea and nobody's done this, And I'm just gonna expand this idea on my own here. I'm gonna go hide in my attic, and I'm gonna create this research project. That's the wrong way to start in developing your question. The right way is to have the idea and think about it and do a little bit of reading about your idea and think about what you want to do. And then you want to discuss with colleagues, a colleague or colleagues, because if you think it's so incredibly novel, you'll be surprised that probably 95% of the time, some version of that idea has been explored, and your colleagues may be familiar with that, and your colleagues may also have some really brilliant ideas that you think you've thought of sort of different angles of how to go. But they have some great idea about, firstly, whether your idea is a great idea, and it's worth bouncing that off of colleagues, and whether there's different approaches that you should be building into your idea right from the beginning. And so it's often really valuable to discuss your idea with people who are outside of your particular field. So if you're a gastroenterologist and you're planning some type of IBD study, it's been enormously fruitful for me in the last 25 years to have clinical psychologists and epidemiologists and other type of internal medicine subspecialists and microbiologists to formulate different studies with, because they bring different perspectives to the idea. I can tell you that the Imagine study started, and I don't think Paul Moietti's on the webinar, but I don't know if he remembers this, but I remember sitting in my basement having a call with Paul when the RFA came out, and he floated the idea of developing some kind of large national trial about this, and we talked about it. Now, Paul could have just stuck with a group within himself and maybe at McMaster, but he had known that I had done work like this, and he's certainly done work like this, and so I'm sure it was a fruitful discussion for him, and it was a fruitful discussion for me, because I wasn't really thinking about entering into that RFA per se, and it sort of got me stimulated to think about what we could do, and hopefully it did enhance Paul's thinking about this, and then obviously we went on to talk with other experts in the country. Now, a new aspect of developing one's question in the last, I would say, 5 years, maybe 7 years, has really been to discuss your idea with patient advisors. And this is a new phenomenon in research in Canada. I can't speak to how in depth this is going on in the United States and Europe, but it's certainly become important in Canada. It's become important to CIHR, which is our main funding agency. And I think that other peer-reviewed agencies are accepting that this is an important aspect of a study. And so, as physicians, we've, even if we don't try to practice paternalistically, we certainly have paternalistically approached research where we have the idea, whether we're physicians or scientists, we have the idea, and we're going to research a specific disease, and we've not necessarily, over the many years, included patients who have the disease to get their views on what would be appropriate. So in the last, let me think, 13 or 14 years, starting with a study that I did with a wonderful rheumatology researcher here in Winnipeg named Hani El-Gabalawi, who's a world-class rheumatoid arthritis risk factor researcher. We conducted a study looking at the intersection between rheumatoid arthritis and IBD in white people and First Nations. People of First Nation descent get much more rheumatoid arthritis than white people do, and people who are white get much more IBD than First Nations do. First Nations people really don't get much IBD at all. And so we developed an advisory group, including white people and First Nations, to talk about these things. And also, if we were going to approach First Nations, we needed to understand what would work in approaching their communities to enroll participants. That's one thing, just purely on an enrollment and how to get your study done basis, the nuts and bolts of getting your study done, patients can tell you what will work. And if it's not patients, it could be consumer groups like Crohn's and Colitis Canada. They are connected with people who have the disease and people who are interested in promoting studies around the disease, and they can help tell you what will work. That's one aspect of engaging with patient advisors. And another aspect of engaging with patient advisors is to really learn from patients what would be important to them in a specific area. And we've done that repeatedly through different studies that we've undertaken over these years, and learn from patients, yeah, it's worth studying quality of life on, in IBD in this area. And then also while you're studying quality of life, it's really important to really tease out information about work-related quality of life. And that led to part of a big study that we were undertaking. The next aspect, once you're sort of putting together your ideas, you've done some literature review, obviously, because you've read a little bit around this area. But now you have to do really a solid literature review. You really want to understand where the literature is at in your area. And that's not even necessarily conducting a systematic review or a meta-analysis, but you don't want to just pull the last 2 papers that were written that you've PubMeded topic A, and you find out what are the last 2 papers that were written in this area. And you read them, and they have a bit of a review, and you're relying on these people to provide their discussion. That's not the way to do it. You really want to get some sense over time where your topic has been. And then after going through these different steps, you can really hone your question. You may have started to formulate the question with your idea, but now you're really formulating the question. And that question may be in the title of your study that you're now going to put together to write to research ethics boards and to write to other colleagues who you're co-opting as co-investigators, etc. And it may be a different question to some extent than the original idea you formulated in point number 1. Next slide, Ida. Okay, so these points here on the slide, there are several, and it's because conducting a study, even if it's what you might think is quote unquote a simple survey study, you have a question and you want to know, as an example, you want to know patients with IBD when they're acutely unwell, what type of urgent clinical service do they want to access? What would work for them? So this is a question you have. You want to understand that from patients. So, well, there's many different ways to answer that question. There's many different, it's not a single result you're going to get from answering that question, because there's many different nuances to answering to the potential answers of that question. And so here are some of the points that you're going to run through when you formulate your idea about what you're really after. And right now, for the purpose of this discussion, we're after the notion about how patients with IBD want to access acute care when they're acutely unwell. Well, so you ask yourself, what will cross-sectional data answer? Is it going to be sufficient to answer this question by doing a one-time question to patients with IBD? Or alternatively, what will longitudinal data answer? Will it be stronger to do this study longitudinally, prospectively, so that you could either ask people cross-sectionally? 80% of the people you ask may be well at the time you ask, so you're asking them to think about what they might want to do when they're unwell. On the other hand, if you do the study longitudinally, you may be able to capture information of what people want to do as they are unwell. Those may be 2 different answers when patients become unwell. The next issue is, who will be the source population? What type of patients can you access? Is this going to be from some research registry? Is this going to be population-based? Is this going to be from a specialty clinic? Which leads into, what does the population represent? If we're doing a study out of a tertiary referral clinic, That may not reflect everyone in the population with IBD. If we do this study from a population-based research registry, it may be more representative. And then if you do the study from a tertiary referral clinic, for instance, at Mayo Clinic in Rochester, Minnesota, is that going to be the same than doing it from a referral clinic at McMaster in Hamilton, which is probably seeing a broader spectrum of society than they're seeing at a referral center in Mayo Clinic. What research tools are available? Do you have the tools at your disposal that have been validated to answer a specific question, or do you have to create the research tools? And you have to take research tools that have been created in one disease entity or for one type of study and hone it for IBD or for your disease. What research expertise is needed? It may be fabulous to think about wanting to do a gut microbiome aspect to your study, but if you do not have gut microbiome expertise and you don't have your friendly neighborhood molecular microbiologist next door or across the hall or even across the country where you could send samples, then you're not going to be able to fully develop that idea and carry it out. And then the next thing is, what research staff is needed? Will you have the research staff at your disposal? What funding would be required to get the research staff? And these are things you have to think of a priori. What approvals will be needed? For all research, you're going to need a research ethics board approval, or in some places it's called an institutional review board, IRB or REB. But for a lot of studies, including a lot of studies that I do, I need other approvals because I may want to use administrative health data of Manitoba Health, and I'm going to need their Health Information Privacy Committee approval. If I want to access very interesting databases that are housed at the Manitoba Center for Health Policy, I'm going to need their approval, and I'm going to need to understand what it's going to cost to access them. If I'm going to do a study with the gang at McMaster and I'm at University of Manitoba, and we need to create a research agreement, I mean, that's the most onerous of all things, because between the lawyers at the U of M and the lawyers at McMaster, and, you know, to be quite honest, it took over a year to get Imagine started, even when we were ready to go and had the interest and energy to go, just to get the research agreement in place between one institution and another. And that's two Canadian institutions that I'm sure have worked together lots on these type of agreements over the years. What analysis do you anticipate? So as you're going forward with your research study, even if you're not a statistician yourself, you should be thinking about what analyses you want to do. And if you're not a statistician yourself, then you need to co-opt a statistician to help you to decide, are you asking the right questions? Will you have the right population to do the analyses you want to do? Or alternatively, these are the populations and these are the questions I'm asking. What analyses will be appropriate to conduct? And then the next thing is, does anything need pre-testing? And I've got pre in quotes to ensure it will work. Now I've got work in quotes because what I'm alluding to is, will you really be able to answer your questions with the tools that you have at your disposal? Is this an ELISA-based clinical trial, a clinical study that you're doing, where you need to measure something in the lab? You're getting patients' serum and you want to measure something. You want to be sure that that assay works. You want to be sure that it's reproducible. You need to understand, are you going to batch sample the sera and then do it all at once? Will that be important? Can you take sera that's been frozen for 10 years because it's been part of a past study you've done? You're going to thaw the sera. Will it work? Will it still be robust? Or do you have a survey and you want to, what we call beta test it? Give the survey to 5, 10, or 20 participants and say, do these questions make sense to you? How long does it take? Will people really do this? And then ultimately, and while you're not doing the study specifically for journal A versus journal B, if you don't publish your research, it's only hearsay. And so you need to publish your research, and therefore you want to be thinking about, how's this going to piece together, and how will I ultimately write this up? Next slide item. So just to introduce the creation of some very important research tools to us in Manitoba, and created a template for developing research tools in other provinces. So this is the brief thumbnail sketch of creating what we call the University of Manitoba IBD Epidemiology Database, UMIBDED. And I started this when I got back to Winnipeg in '93. I hooked up with my friendly neighborhood provincial epidemiologist, Jamie Blanchard, who's a wonderful guy and probably one of the world's leading global health epidemiologists. And at the time, he was the provincial epidemiologist, and we went to the Manitoba Health database, which was perhaps the most well-developed in Canada, from identifying people uniquely, going all the way back to 1984. So we identified people within the Manitoba Health database from 84 to 95. There were 10,500. We created some rules for ourselves, having never done this before. If a person had less than 3 contacts for a diagnosis of IBD in the database prior to 1993, that is only 1 or 2 contacts, we excluded them. And we excluded them because we really wanted to more maximize specificity, even though we knew we were sacrificing some sensitivity. We wanted to be sure we were really getting at people who truly had IBD. And if they only had 1 or 2 contacts for IBD, how likely was it that they had IBD? We went through Manitoba Health, and we sent out mailers to all people. They were anonymous to us. We actually went through doctors' offices in Manitoba. I spent the first 2 weeks of my career in Manitoba on the phone with doctors across the province. I called well over 200 doctors, asking them if we could either do mailouts through their office that they would do themselves, or that we would send a researcher to their office to conduct the mailouts. And we asked people through the mailouts, do you really have IBD? Will you answer these questions? Will you consent to be part of our study? We got what we thought at the time was an excellent 60% response rate, remarkably almost 50-50 Crohn's and UC. We got some people who told us, no, I really don't have IBD. Many of them said I have IBS. We then went back to Manitoba Health. We got their approval to look in their administrative data. We analyzed their medical contact patterns. We optimized a case definition versus their self-report. And then we did a random sample chart review and evaluated the case definitions. And then we created what we call an administrative definition of IBD that we could apply to the Manitoba Health data, and created our IBD database. And using that kind of methodology, we've developed an MS database in Manitoba, and our friends across the country have really developed similar databases in Alberta and Ontario and elsewhere. So it's been a very productive tool. So we have an administrative database that we can continue to update, and we could go to anonymously on a population basis describe a number of outcomes, which we'll get to. And then, Ida, next slide. As part of developing the administrative database, we also had these 2,500 people that told us they had IBD. That was roughly half of all Manitobans with IBD. And we created what we called our University of Manitoba IBD Research Registry. So these are now people that have become known to us. We're inputting them into a registry, and we could contact them. We asked them specifically, and 90 to 95% said we could. Can we contact you for future studies? And that way, while the epidemiology database was anonymous, we wouldn't know who they were, we couldn't contact them. With this research registry, if we wanted to ask them other questions, other surveys, if we wanted to collect their blood or other tissue samples, then we'd have this registry. And obviously the registry was only going to be as good as continuing to update it on a go-forward basis. If we just left the registry back in 1995 as is, it's now 2020, not least of which is some of those patients are dead. You need to continue to update your registry. Next slide. So I just want to run through a few studies that we've done here in Manitoba to give you some examples of how we've used our different tools. So this is the Manitoba IBD Risk Factor Study. It was one of the first large studies that we did. This was a population-based case control study, and it was population-based because we drew the participants out of our population-based research registry for those who had IBD. And then we went to Manitoba Health, and we got matched healthy controls from the Manitoba Health Registry. We sent out mailers to 5,000 Manitobans and said, hey, will you fill out the survey? will you give us a blood sample? And remarkably, 10% of Manitobans, without paying them anything, were willing to do this. And so we got 500 controls, and they were matched by age, sex, and geography to 500 persons with IBD. And then once we got the IBD patients as another interesting control group, we asked them if they would enlist or we could access their siblings so that we would get non-affected siblings, for obvious reasons why that would be an interesting control group compared to healthy controls that were unrelated and didn't have the disease. Next slide. Now, I'd mentioned that came from the research registry from the University of Manitoba IBD Epidemiology database. We've been able to conduct a number of studies. In many ways, these are easier to conduct because they're the cute term for this, as opposed to in vivo or in vitro, is in silico. And one can sit at a computer terminal and pull out the data that one needs. And although we've made it a little bit more complex than that in terms of the linkage with other databases that we've undertaken and some of the sophisticated methods we've used to, for instance, link identified persons with IBD with their mothers in certain studies we've done. But we've done burden of disease studies and trends over time. We've done clinical studies looking at comorbidities, medication use, patterns of surgery, healthcare utilization studies, and really my favorite aspect of using epidemiological data is to do etiologic hypotheses generating studies. As I said, we started this in 1995 or so, but soon thereafter, databases were developed in Alberta, in Ontario, in Nova Scotia. We conducted a 5-province study using this methodology in 2005, 2006, with funding from Crohn's and Colitis Canada. And then, about 5 to 7 years ago, time is flying by, Eric Benchamal led a group that we call CanGeek, and he has been the leader of assembling investigators, myself included, in Winnipeg, as well as other investigators locally here in Winnipeg, with particularly Gil Kaplan and others in Calgary, and Eric and Sanjay Murthy and Jeff Nguyen in Ontario, and friends in Saskatchewan and BC and Quebec and Nova Scotia. But predominantly over these last 5 years, we've been productive at reporting concepts out of Alberta, Manitoba, Ontario, and to some extent Nova Scotia. And you can see how that would strengthen not only the study by increasing the power. We have so many participants, but also the representability of this, because we're really covering much of Canada. Next slide. Now, the next large study that we tackled, which has really been a really important study for our group and was really one of the first large studies to tackle psychiatric comorbidity in IBD, and has really set some of the groundwork for a lot of the great things we hope to do with the Imagine study, we call the Manitoba IBD Cohort study. And I co-opted 2 amazing people, Leslie Graff and John Walker, who are clinical psychologists and wonderful clinicians, wonderful researchers, and wonderful humans. They've been great people, great friends, and really I've learned so much from both of them. John both of them became important integral members of the Imagine research team, and tragically John passed away last year, which has been a huge loss, certainly for me research-wise and for me personally in particular. So with this study, we were wanting to describe predictors and patterns of outcomes among subjects diagnosed within 7 years. So that seems like an odd number. Why would you care about subjects within 7 years? And so the way that evolved is that when I started to put the study together, I really wanted to get people with early disease. And so that I'd get enough people, I was looking to enroll people within 5 years of diagnosis. But by the time you got funding and by the time you got approvals, people within 5 years all of a sudden are stretching out to within 7 years. And so this is how one's studies kind of evolve and morph. And so we were doing some meticulous chart review to define participants' phenotype. We were collecting blood to get DNA to ultimately define a genotype. And then we were also getting their approval to link their data that we're collecting with their administrative health data, so we could look at healthcare utilization. And so you could see that in developing what was predominantly a survey study, where we were surveying people every 6 months with surveys and every year with an in-person interview, that we were thinking ahead and saying, well, let's also, one day we may want to look at their administrative health data. Let's get that approval. We're not necessarily know what genetic study we're doing today, but let's collect their blood so that we'll have their genes, because they're going to be a rich resource. Next slide. So I'd mentioned this, you need to have the foresight, even if you're not going to affect some of these studies today, you need to have the foresight with what you may want to do in the future. And so we banked serum and DNA on these people. Next slide. Now, another study that we undertook, and I've alluded to this study that we had CIHR funding for, called the Arthritis and IBD Study. This is the study we undertook with Hani El-Gabalawi, where we enrolled people with IBD and rheumatoid arthritis, as well as healthy controls that were either Caucasian or First Nation. Our goal was to contrast these diseases between these ethnic groups for the reasons I alluded to before, the differences in incidence for IBD or rheumatoid arthritis, depending on your ethnicity. We undertook surveys, we banked serum, we banked DNA. And while there was some very interesting data that came out of the study, one of the great things that came out of the study was the research tools we created by having developed healthy control cohorts, where we had serum and DNA from healthy white people and healthy First Nations. And actually, Hani El-Gabalawi has used this to even greater advantage than I have, as the many studies he's done in the First Nations populations, he's had access to a serum and DNA bank of healthy First Nations. So while you're creating your own study to explore certain questions that you have, you're also potentially creating tools that can be used for other studies in the future. Next slide. Now, another study that we undertook was to try to understand what was a predictor of a disease flare in IBD. And with this study, we went to our population-based research registry and we drew out a cohort. We asked the 3,000 people that had accessible addresses at the time who would be willing to participate in a survey where we surveyed people every 3 months for 1 year. And we got about 600 people to do this. And we were asking them about disease flares based on survey. We're going to talk a little bit more about this, so we could really get at their symptoms. But we really wanted to also understand their actual disease inflammation. And so we published on that study, and then we repeated the study, and we did a second study that was drawn from the same registry, and we asked people if they would be willing to submit a survey every 3 months for 6 months, so that's 3 surveys, but also each time they submitted a survey, submit a stool sample so that we could measure a fecal calprotectin. So you could see how we've built on our first study methodology and made a different type of study where we could look at both symptoms and disease activity. Next slide. Now, one of the more recent cohort studies that we've undertaken here in Manitoba, this is also CHR funded, and the nominated principal investigator is Ruth Ann Mary, and I've alluded to her. She's a world-renowned MS epidemiologist, and we're looking at psychiatric comorbidity and chronic immune diseases. So drawing on the work we had done in IBD with psychiatric comorbidity, we were now going to include cohorts with rheumatoid arthritis, with multiple sclerosis, and a separate cohort that had no chronic immune diseases, but that had mental health disorders, depression and anxiety. And our goal was to define the burden of psychiatric comorbidity in these chronic immune diseases. We wanted to create tools to easily identify them in practice and tools to help deal with them in primary care. And this study is really now, to some extent, coming to a close. It started in 2014. Next slide. The primary grant was to look at both survey data and administrative health data. And so we have done this over time. I've already alluded to some of these studies that we've done in Manitoba. we're looking at some outcomes cross-sectionally, and because we're following people every year over time, we're looking at some outcomes longitudinally. And we've adopted this approach with Imagine. We're enrolling, we hope, 8,000 people by the time we're done, 4,000 people with IBD, potentially 2,000 people with IBS, and we're going to have lots of information on them cross-sectionally, but if we follow them over a few years, we'll also have longitudinal data that can allow us to ask different questions. Now, in our original study with Ruth Ann, we didn't have biologic questions built into the grant, but we said we were going to bank blood so that we'd have serum and DNA, because we have this very rich resource, and in fact, we are now tapping in to the serum and DNA for other biologic studies. And building on this study, Ruth Ann got a grant with MS Canada, and I got a grant with Crohn's and Colitis Canada to look at structural and functional MRI in some of the people with MS and IBD within our cohorts, as well as some healthy controls and controls with mental health disorders who don't have immune-mediated inflammatory disease. So an important message is to be, as you're creating your study, think about the future. It's like the way we treat IBD. We're treating them and giving them a treatment today, but we're also thinking of how we're going to keep them in remission over time. And we're also thinking about plan B if one of these treatments don't work. We're creating our study here. We have the methodology nailed down for the questions we want to answer today, and we're building in some ability to potentially take the studies in different directions tomorrow. Next slide. Now, when we do these studies in IBD, and all of the studies I've done, we need to ask ourselves, we want to compare what happens to people who have active disease compared to people who don't have active disease. And so the question is, well, how do we measure disease activity in IBD? This seems, if you haven't really thought about doing research, it seems almost intuitive. If you've been in an IBD clinic, well, we know when people are sick and we know when people aren't sick, but you have to document this, and there has to be some objectivity and there has to be some reproducibility to it. How would you measure this in a cross-sectional study, and how would you measure this in a longitudinal study? Well, this came up as a potential problem when we developed the Manitoba IBD Cohort study, which was that 12-year, every 6-month survey study, every year annual interview study. How were we going to define if a person had active disease? If we use some of the tools that are out there, like the Harvey-Bradshaw Index, which is well known, even if we went to the trouble to use the Crohn's Disease Activity Index, which has been widely used in clinical trials, the truth is that's giving us activity over the last week. Somebody could be very sick in the last week and enormously well for the first 5.5 months if we're seeing them every 6 months, or alternatively, they may have been very ill 3 months ago, and by the time we're interviewing them at the 6-month mark, they've been very well. And if we ask them how they're doing, they say they're doing very well, but we will have missed the fact that they actually had active disease at some point. Next slide. So we developed what we call the Manitoba IBD MIBDI Disease Index, the Manitoba IBD Index, and we asked one question for the cohort study. In the past 6 months, my disease has been constantly active, often active, sometimes active, occasionally active, and if they answered A through D, we considered them active, and if they answered rarely active or being very well, we considered them inactive, so we dichotomized this. Next slide. So we've published the Manitoba IBD Index, and Ian Carr was the first author of this, who helped us with the metrics on this. And this is a tool that's been used in cohort studies and other people. It's non-proprietary. We let anybody use it. It's very simple, and sometimes it has to be adapted in certain ways, but it at least is it's getting at where you've been in the last 6 months, as opposed to picking an index just in the last week. If your study happens to be surveying people over long periods of time without surveys in between. Next slide. Now, sorry, this is a duplicate. I didn't mean to have that. Next slide. Now, we also wanted to improve upon indices like the Harvey-Bradshaw Index or the simple UC Index, and we developed our own IBD symptom inventory. Catherine Sexton led this, and we validated this. And next slide. And we undertook this study that Kelsey Whitkus led, the Manitoba Living with IBD study, where we surveyed people every 2 weeks online for a year. We also collected their fecal calprotectins and a special survey when they were self-reported a flare. And what you can see here is that people who flared, and we also collected controls, people who flared were more likely to have an elevated fecal cal than people who didn't flare. But there were some people who flared who didn't have an elevated fecal cal, and there were some people who didn't flare who did have an elevated fecal cal. And this just reminds us of the difference between having active symptoms and having active inflammatory disease. Next slide. Now, we learned a number of things with this Manitoba Living with IBD study. We learned how to use REDCap, which was a new tool. We learned how to use REDCap longitudinally. We learned how to develop a medication list that could pre-fill for biweekly surveys every time a subject was going to tap in. They didn't want to re-enter their drugs. We gave people incentives financially to complete the surveys, and we think that was an incredibly productive use of our grant money because we really got great retention rates. We needed a research assistant to meticulously provide participant stewardship. And Kelsey Whitkus did that incredibly well, and we got a 95% retention rate of 155 people at the end of 1 year. And we need to develop a courier service to get stool samples when we were surveying them when they were flaring to get their fecal cal. Next slide. And the last big study I want to just highlight that we've undertaken is a study looking at disability and work issues in IBD. We undertook the study to validate an IBD-specific disability index, what we call the IBD DI. We wanted to understand work issues in persons with IBD, and certainly our patient advisors wanted us to understand this. We wanted to understand choices for acute care for persons with IBD, and we wanted to determine how having high disability impacted upon healthcare utilization. Next slide. We learned about the Dillman Method, and we utilized the Dillman Method, and we can talk about that in the discussion, which is a method of really maximizing your return on surveys by contacting people frequently. We used the research registry that I've alluded to so that it was population-based. We had a sample of interested participants, and we got their consent to link to administrative health data so we could look at both surveys and administrative data. Next slide. So these are some of the studies that have come out of this study. The first study was looking at workplace accommodation, an important issue for persons with IBD. We then validated the self-report version of the IBD-DI. We adapted the IBD-DI. We didn't invent it ourselves. We adapted it from a interview version that Laurent Perrin-Biroulet and his team had published on. But an interview version is going to be costly and more time-consuming than a self-report version. And then we looked at another issue that was important, both to patients and to us, presenteeism, which is work productivity when one is at work, as opposed to just absenteeism when people are missing work. Next slide. We did look at healthcare utilization and looked at factors associated with service utilization and preferences for service options for that routine and urgent care. I alluded to that kind of study. That was part of the survey. And then we looked at their administrative health data when we looked at health indicators of moderate to severe IBD related disability based on surgery, hospitalization, high use of steroids, and anti-TNF use. We have a few other papers coming out from this. We want to cost out care, and we've also got a paper in submission right now where we've had friends and other centers outside of Winnipeg looking at the same IBD-DI tool. So we can validate it to its robustness in different populations. Next slide. Finally, I'm just going to mention that we've also looked at other tools that are used in other disease states that we've adopted for IBD. And when you're asking yourself the question in this paper, for instance, this is the Psychiatric Comorbidity and Chronic Immune Disease study that we've undertaken. There are many different ways to ask about depression and anxiety. And if you can see this table well enough, you can see that depending on what tool you used, whether you use the PHQ-9 or the HADS or the PROMIS, you may have a different outcome for how many people are depressed or how many people are anxious. Next slide. These ROC curves show that regardless of what tool you used, you get reasonably comparable outcomes. Next slide. But we actually did sensitivity analyses, and using the SCID, a gold standard interview, sorry, the next slide, Ida. This table, table 5, we actually created different cut points based on our data for the different tools that are already in use. So we would use a different cut point for the HADS for depression than for the HADS for anxiety, and then for what's been published and used in other disease states. So this has been a valuable exercise and provides for the research world some information about what type of psychiatric tools one might want to use and what cut points work best in IBD. Next slide. One thing you can do, and we're in the process of doing this with Imagine, is you can publish your research protocols. And so everybody can really get to the nuts and bolts of what you've done and what's available to be studied from those protocols. And these are 2 studies that we published in JMIR. This was the Living with IBD study protocol, and the one on the bottom is the Psychiatric Comorbidity and Chronic Immune Disease protocol. And if you guys want to see some of the more details of this study and how we put it together, you can access those publications. Next slide. So this is the final slide, I think, and what you need to do, obviously, is you're going to have research tools that you develop. You need to update them so that they can be contemporary and usable in 2020, just like they were in 2005 or even in 1995. So we continue to update our IBD based on the administrative definitions we have, and we continue to update our research registry every 5 years. We're in the process of doing that by doing mailouts to people across the province who have IBD, drawn from Manitoba Health, so that we could potentially enroll them in our registry. Next slide. So that is a torrid tour of different approaches to clinical research in IBD, and Ida, I'll let you steward the few minutes we have remaining for questions or comments.
Thanks, Charles. That was great. So yes, I'm inviting everybody to please enter your questions in the chat box area. I will use this opportunity, Charles, maybe to get things going, is what advice can you give for investigators that are participating in research when working with industry then?
So the issue with, there's 2 things with industry that I think are really important. One, you need industry because it's very hard to fund these studies based on 13 to 15% funding rates with CIHR, and especially now in this COVID era with the uncertainty what the disease support groups, charitable organizations are going to have, when we come back. This is no fault of CCC, but people aren't working. There's less money to raise. There's less opportunity to get people together for barbecues and whatever other money-raising ventures they may have. So industry is another source to potentially get money. It's a little bit arduous, but it can be worthwhile, and I've done this on occasion. A handful of times I have gotten certain studies funded from industry. Obviously, and you could tell by the studies that I've presented today, few of them are, if none of them really, are related specifically to the drugs that those pharmas are selling, and I find it a lot easier in my own, from an integrity point of view. If I'm getting money from AbbVie or Janssen, I'm not studying Humira or Remicade or Stelara. They're willing to put their money towards other studies like I've alluded to. The second thing I would say, so other than the importance of being having a relationship with industry, as a researcher, you want to own the data. So you don't want to sell your soul, and you don't want to just for the $100,000 or the $20,000 that you may get. You don't want to give up your research outcomes to whoever is supporting you. So you have to be careful in that way.
Thanks. And just to address the other areas around patient engagement. So do you have any tips on how best to engage patients in research design and implementation?
So there's two issues there. One is patient engagement in developing your study. The other is getting patients to engage to participate in the study. Those are two different things. Patient engagement, I find that patients, I don't even know the exact number, but probably close to 2,000 patients with IBD that are seen in our center at some time, not all the time, not every year, but at some time. And there's a lot of patients in there that are very interested in, participating and thinking about studies. And I think that what I have found valuable is to have sophisticated patients who may have advanced degrees, who may be financial experts and who have different perspectives on sort of financial aspects to research. And I think it's also valuable to have, I'm going to call them unsophisticated patients. I don't mean to be derogatory, but people who are of modest, either socioeconomic means or modest educational backgrounds, who are just giving you from the soul and from their heart, this is what affects me, because they're the majority of your patients anyway. So you want to have a broad spectrum of patient advisor participants. You don't just want to rely on who's the loudest patient in your clinic. And I think that you need to be respectful of their time. They're really doing you a favor. You need to have meetings that work for them at the right time, at the right place. And now we've come to learn that many of these meetings can be undertaken like we're doing today on the web. And I'm not sure that we're ever going to have patient advisory meetings in person again. I just don't know. So I think that every center can develop a patient advisory group in every disease group. I really think that this isn't some unique thing to what we've done in Manitoba or what we've done in the Imagine study. In terms of really engaging patient researchers, I would defer to Deb Marshall, who's now a co-PI in our Imagine study and has been involved with us, who's really done an incredible job in developing patient education programs of how to make patients into collaborative researchers. So I'm probably not the best person to answer how to optimize that. In terms of patient participation in the actual study, I'm always amazed when patients don't want to participate in easy studies like surveys. And it surprises me. And I think it's a whole other area of research that we need to tackle. Why don't patients with IBD sometimes not want to participate in studies about their disease? I still am always amazed by that.
Okay, so I have a question here from William Hall, and he's a PhD student in health economics. He's really interested in the costing and absenteeism and presenteeism. What opportunities do you think there might be to apply health economic evaluation using these rich databases you discussed?
So, William, that's really a great question, and I would probably defer back to you as an expert in health economics, of which I'm not, as to how to optimize applying costs. We do have a health economist named Julia Witt working with us, who's at the University of Manitoba, and we've got a gastroenterologist who just joined our faculty literally yesterday, who did his Seth Schaefer, who trained with us and did a master's in health economics at the University of Chicago. And so we're actually now on the threshold of determining how to understand how to apply costs to those what would fall under the category of indirect costs of the management of IBD. And perhaps, William, we'll find ourselves working together, as we're certainly open to collaborative research on how to optimize approaches to this. So we're actually just working through that right now. That is something we're working through. We're in the midst of taking our data that use that database, we call it the disability database, but includes questions on presenteeism, absenteeism, workplace accommodation, et cetera. And we're going to try to understand what costs there might be. Some of the complexities of that is understanding what the different professions are, and obviously there are different specific financial losses by being in one profession or another. You know, if a doctor misses 3 days of work is different than whether a nurse misses 3 days of work, whether a welder misses 3 days of work, in terms of the costs to society and the costs to a person's pocketbook.
Thanks. And so another question here around getting multi-center studies going. So even just for collecting data, there's so many agreements and barriers. If you can just comment on how you've managed to be successful in this area.
Sorry, Ida, we're talking about multi-center studies outside of Winnipeg, multi-center studies across Canada.
Yeah, I'd say across Canada. That's a
right. So it really depends on what kind of study you're doing. For instance, when we did the study where we got 5 provinces to pull their administrative data, it was easier in the sense is that I needed to co-opt an investigator who got access to administrative data in BC, Alberta, Manitoba, obviously we had our team, Saskatchewan, and Nova Scotia. So there was a smaller group of people that we needed to collaborate with. Similarly with CanGeek, that the group that Eric Benchmall has been leading for some years, where we're looking at admin data, we've really got 2 or 3 principal investigators in each province, and then 1 or 2 analysts in each province. And so there's a small group of really 6 to 12 people that are meeting regularly and are getting the work done. It's much harder to do a study like Imagine or a study like the GEM project that Ken Krotoru has led, where you're relying on 10 or 15 or 20 centers to have potentially different investigators enroll hundreds of people, because you're now relying on patient participation, and that's always different. And then once you get the patients enrolled, and we've struggled with this with Imagine, it's one thing to get their surveys. It's another thing to get them to bring in a stool sample. That's something that's very germane to IBD studies, but people don't want to part with their stool for some reason. And that's been a difficulty that we've experienced in many studies. I think the important thing when you're doing collaborative research studies is to make sure that your collaborators, once they start and they're enthusiastic, that they're very much kept in the loop and that they know that they're important and that they're going to get the credit for participating with you. The moment your collaborators start to see that you're going to be a runaway train with the research and the data, and they're maybe left in the dust, they're going to drop out. So you definitely want to make sure that, and not just in a public relations perspective, but in a legitimate way, that your collaborators are really a part of the research and are important in it.
So I think we have time just for maybe, if we can make them brief, maybe 2 more questions here. In what areas do you think more research in IBD is needed, and what are the challenges associated with undertaking that research?
Well, the area of IBD where the most research is needed and has been, I think the hardest nut to crack is etiologic research and trying to tease out cause. And cause and effect means that you're actually tackling a marker that happens before the actual disease process is underway. There's an editorial that I wrote in Gastroenterology that's actually just online, I think, today, about 2 very interesting studies. One published in Gastro looking at heavy metals that can be identified in the teeth of newborns, of babies, of infants, their infant teeth, and how that may relate to ultimately developing IBD. And a second study looking at a huge serum bank of people before they were known to have IBD in a military serum bank. And so, whatever associations you find, it always begs the question of what really came first. When did the disease start? So I do think that etiologic work is really the big bugaboo. The second area that's been, I think, a goal of many of us and hard to define is we have a wide array of therapies. We have lots of monoclonal antibody therapies now, and we're developing microbiome focused therapies. The Imagine study is involved with looking at some fecal transplantation work. And we know that whatever study results we get, even when they're statistically significant, it's a small segment of the population that responds to any one therapy with remission. And we've not really been able to define who are the responders and who are the non-responders. I think those are two huge areas that I think will really move the field forward.
And just for our last question then, how do you balance overburdening participants with questionnaires and collecting as much information as possible that could be used later?
So that's an important question and a very hard one to answer. And, we're starting a new study that we're going to go back to our registry that's going to have to do with COVID-19. Obviously, that's a hot topic, and that'll be important to understand in our IBD population. And we created the survey that has a number of different components, and it's a big survey. It's dense, and it actually takes about 45 minutes. Part of it is going to be with what the participants are interested in. And so what's going to motivate them to finish this? I alluded to in our disability study, the one where we use the Dillman method with frequent reminders to patients. We actually paid patients. And I think that there's a lot to be said about including a financial incentive, even if it's small. There's a literature on this that, if you give people a $5 or $10 gift card, if they're going to take it, they're going to feel a little bit more obligated to complete your survey rather than just tossing it out. So I think you have to balance when you really want to get all the information you want with making something very long. In our Living with IBD study, we had 26 surveys every 2 weeks for a year. So at baseline and at 1 year, we had 45 to 50-minute surveys. But every survey in between was 10 to 12 minutes. We made them briefer. And so to keep people engaged, if you have a lot of questions you need to get at, you can't do that every other week. And so you have to, as a researcher, decide what you're willing to sacrifice, because you can't do it all.
Great. Well, thank you so much, Charles, for a fantastic talk. It was really useful to hear that overview of the impressive body of work that you've put together, and there was, I'm sure, very helpful for our participants. So thank you again for joining us today, and thank you to Dr. Bernstein, and we hope to see you next month.
Thank you, guys. Bye.
Bye, Charles.